Shared transmission pathways, there's a considerable overlap of HIV and hepatitis C co-infection. We estimate that, at least according to the new figures, around 4 million worldwide should have hepatitis C on top of their HIV infection. Clearly, we also understand, and that's clearly one of the challenges for the future, that we need better surveillance programs. Many countries cannot describe their actual infection rate. And clearly, if everyone is curable, we have to know who it is so that we can identify and bring therapies to people. And that would include that we also need better diagnostic methods, which much easier and cheaper allow the diagnosis of replicating hepatitis C, which would then enable corresponding treatment. I think the hallmark of hepatitis C and HIV is really, unfortunately, the much faster fibrosis progression. And the early years of co-infection were determined by the increased toll of liver morbidity and mortality, and people started to die from liver disease once HIV became controllable. And in the realization of that, there has been a real struggle in the community to find optimized treatment regimens, because unfortunately, co-infected patients responded much less favorably to interferon-based regimens when they were combined with ribavirin than mono-infected patients. In the most common genotype, so hepatitis C exists in different genotypes, genotype 1, which accounts probably for 2/3 of the infections, the overall cure rate were probably not higher than 30%, really limiting the overall treatment access. Also, the high burden of adverse events further limited the widespread use, and it's was unfortunate, at least, that only 10% of the North American, probably around 15-20% of the European patients ever received a hepatitis C treatment in the setting of HIV and hepatitis C because of the perceived low response rates and the very high burden of adverse events. Now, within the last 2 years, this has all dramatically changed. And in the hepatitis oral session yesterday, it was really quite amazing to see that we had 4 different drug combinations being presented, which all came out without interferon and most likely also without ribavirin, demonstrating cure rates on average above 95%. And that included treatment-experienced patients, so those who had failed on interferon and ribavirin, included those patients who had cirrhosis. And that really is a tremendous breakthrough because it really indicates several things. First, it indicates that there's no longer separation between co and mono-infected patients. They actually respond just the same way. So there's really no barrier anymore to say lower response rates would prevent treatment uptake. And in the setting of a still faster fibrosis progression and a higher risk of hepatic decompensation, we would emphasize that there remains a prioritization in treating HIV and hepatitis C infected patients. And indeed, when you go to many programs which are established worldwide, for example, Brazil and other countries, all patients with HIV and hepatitis C actually get access to treatment independent of fibrosis. And I think one thing I want to highlight from that oral hepatitis session, talking about scientific advances, I think one of the important issues also for those people who in the end pay the drugs is to understand what is the consequence of achieving a cure, which we call SVR, sustained virologic response, which is a negative hepatitis C RNA 12 to 24 weeks after stopping therapy. So what does that mean for someone? And the most, I think, important thing is that it does not only decrease the risk of dying from liver disease, but it also improves overall survival, really indicating that hepatitis is not only something which affects the liver, but ongoing viral infection causes inflammation and has an impact on other organs. I think that's the one message. And the most important message for me yesterday from that session was that actually a Spanish colleague, Santi Moreno, showed that if you achieve fibrosis reduction under successful hepatitis C therapy on top of your SVR, that has the biggest impact on improving survival, which means if you have very advanced cirrhosis, you may not really have a regression to earlier fibrosis stages, and your benefit on survival may be limited. Whereas if you get treated early enough, you have the full benefit of therapy. And it's a real strong argument for earlier treatment. And I think what we're currently seeing, and I'm sure Tracy's going to touch upon that as well, is that access due to cost constraints is limited to advanced fibrosis stages. But are they going to benefit to the same amount as early treatment? Regardless of also mentioning that obviously earlier initiation of therapy is associated with shorter treatment durations and less costs altogether and easier application of therapy. So I think what the challenge remains for the future is to convince payers that really everyone should be treated with co-infection, regardless of fibrosis stage, and come up with a public health approach which allows a very simple pangenotypic regimen, which is not given longer than 12 weeks, achieves cure in more than 95%, and can be done on the basis of a very simple dry blood spot diagnostic tests, which shows indicative or replicative hepatitis C, and then allow global eradication.